السلام عليكم.
عليكم السلام.
Good afternoon, everyone, and welcome to our academic activity for today. So today we have 3 lectures, inshallah. The first one will be about Episteme's Anomaly, will be presented by Dr. Abdullah Shahri, and 2 lectures to be followed, to be presented by Dr. Ahmed Alwi about single ventricle and palliative operations in congenital heart disease. So we'll start in 5 minutes, inshallah. Abdullah?
Yes, Dr. Lai.
Yeah, you can start. Yeah, just before starting, I would like to welcome Dr. Atizaz Dean, who's a congenital surgeon from Medina Cardiac Center, who will be moderating this session. Thank you, Dr. Atizaz, for your attendance. You can start, Abdullah. Thank you.
Okay, good afternoon, everyone. First, I would also thank Dr. Atizaz to accept this invite to this activity. We will talk today about Episteme's anomaly. So Episteme anomaly is a rare congenital heart malformation or disorder accounting for less than 1% of all cases of congenital heart disease. This anomaly was described by Abystine in 1866 in a report or a case report titled with the title concerning a very rare case of insufficiency of the tricuspid valve caused by a congenital malformation. And the case was a patient was a 19 years old cyanotic man with a dyspnea, palpitation, jugular venous distension, and cardiomegaly. On autopsy or at autopsy, Episteme described the anomaly that there was enlarged and fenestrated anterior leaflet of the tricuspid valve, and the posterior and septal leaflet were hypoplastic, thickened, and adherent to the RV. And there was also a thinned and dilated atrialized portion of the RV, also an enlarged right atrium and as a PFO. So the pathological anatomy of the tricuspid valve in this malformation. In the normal heart, the tricuspid valve consists of 3 leaflets, the anterior, posterior, and septal leaflet. In Abystine anomaly, the malformation of the tricuspid valve and the RV are characterized by first, adherence of the septal and posterior leaflet to the underlying myocardium. Second, downward or apical displacement of the functional annulus of the tricuspid valve. The third is dilatation of the atrialized portion of the RV with various degree of hypertrophy and thinning of the wall. Fourth, redundancy, fenestration, and tethering of the anterior leaflet. And the fifth one is dilatation of the right atrioventricular junction at the level of the tricuspid annulus. In a normal human heart, the downward displacement of the septal and posterior leaflet in relation to the anterior mitral leaflet is less than 8 millimeter per meter square in body surface area. So the point of maximal displacement is at the commissure between the posterior and the septal leaflet. And the spectrum of the malformation in Episteme anomaly may range from only a minimal displacement of the septal and posterior leaflet to an imperforate membrane or muscular shelf between the inlet and the trabecular zone at the right ventricle. Also, the anterior leaflet is generally redundant and may contain several fenestration, and its chordae tendinae are generally short and poorly formed. And moreover, the anterior leaflet of the tricuspid valve may be severely deformed, so that the only mobile leaflet tissue is displaced into or toward the RVOT, which might lead or causing an RVOT obstruction. So this is an like a 4-chamber picture of the heart with a severe Episteme anomaly. as we can see in this picture at this site, this is a marked downward displacement of shelf-like posterior leaflet with attachment to the underlying free wall by multiple or numerous muscular stump. And this is the markedly dilated atrialized portion of the RV. And this is the small portion or small functional portion of the RV. And also there is a marked dilatation in right atrium. So in Abystine anomaly, the RV is divided into two regions: atrialized portion of the RV and the small functional RV. The small functional RV is also consists of mainly two parts. The trabecular part will be at this side, and the outlet part. Also, we can see in this anomaly, there is an leftward bowing of the ventricular septum, and also decrease in size of the left side of the heart. So regarding the classification of the Abystine anomaly, in 1988, Carpentier proposed classification of Abystine anomaly. We will see later on. And also there is an Ecograding score for neonate with Abystine anomaly. So this is a Carpentier classification, has 4 types. Type A, as we can see in the picture here, small but contractile atrialized chamber with mobile anterior leaflet of the tricuspid valve. And also the volume of true RV is still adequate. In type B, there is a large atrialized component of the RV exists, but still the anterior leaflet of the tricuspid valves can move freely. In type C, the anterior leaflet is severely restricted in its movement and may cause a significant obstruction for the outflow tract of the RV. Type D, almost complete atrialization of the RV, except a small component of the outlet part. And the only communication between the atrialized RV and the infundibular part or the outlet part is through the anteroseptal commissure of the tricuspid valve. So the Ecograding score for neonate with Abystine anomaly is graded from 1 to 4. So this score is calculated by the combined area of the right atrium and the atrialized portion of the RV is compared to the combined area of the functional RV plus the left side of the heart. So if the ratio is less than 0.5, so this is a grade 1, between 0.5 to 0.9, it's a grade 2, from 1 to 1.49 is grade 3, and 1.5 and more, it's a grade 4. Associated cardiac malformation or anomaly in Abystine in patient with Abystine anomaly, and interatrial communication is present in 80 to 94%. Additional associated anomalies include pulmonary atresia, hypoplastic pulmonary artery, bicuspid or atretic aortic valve, subaortic stenosis or coarctation, mitral valve prolapse, accessory mitral valve tissue or muscle bands of the left of the LV, also ventricular septal defect. The pathophysiology of Abystine anomaly. So the functional impairment, there is a functional impairment of the RV associated with regurgitation of the tricuspid valve. These two will retard the forward flow of blood through the right side of the heart. In addition to that, during the contraction of the right atrium, the atrialized portion of the RV will balloons out and act as a passive reservoir, thus decreasing the volume of ejected blood. And the overall effect on the right atrium is dilatation, increasing the size of an interatrial communication, and also it will increase the tricuspid regurgitation by annular dilatation. Also, if there is an associated heart condition, Abystine anomaly, it will has a further effect on the physiology or pathophysiology of the patient. So clinical features, the cardinal symptoms in Abystine anomaly are cyanosis, right-sided heart failure symptoms, arrhythmia, and sudden cardiac death. The hemodynamic variation and clinical presentation depend on the age at presentation, anatomic severity, hemodynamics, and degree of the right to left interatrial shunt. On examination, the jugular venous pulse rarely shows a large V wave, despite severe regurgitation. This is because that the large right atrium will engulf the increased volume. A widely and persistently split second heart sound and several added sounds are typical in patients with Abystine anomaly. Systolic murmur may be also audible, and digital clubbing depends on the degree of cyanosis. An Abystine anomaly Abystine anomaly is a common lesion referred for a fetal echo because severe forms may lead to cardiomegaly, hydrops, and tachyarrhythmia. Neonate with Abystine anomaly may present with cyanosis, congestive heart failure. Symptomatic children with Abystine anomaly may have a progressive right-sided heart failure. And children more than 10 years of age and adults often present with arrhythmia symptoms. Adults also can present with progressive cyanosis, decreased exercise tolerance, fatigue, or right side heart failure. In the presence of an interatrial communication, the risk of paradoxical embolization, brain abscess, and sudden death increases. Diagnostic imaging or study for patients with Abystine anomaly. The echo is the diagnostic test of choice for patients with Abystine anomaly. And it is largely obviated the cardiac cath. It allows accurate evaluation of the tricuspid valve leaflet and the size and function of the all heart chambers. And also we can calculate the echo score grading. So this is a picture from four-chamber view of patient with a severe or a form of Abystine anomaly, which showing grossly displaced septal leaflet of the tricuspid valve. And also the anterior leaflet is almost immobile, and the functional, as we can see, the functional RV is small, and this is the atrialized portion of the RV. This is the dilated right atrium, and there is little bit is leftward bowing of the ventricular septum. ECG almost in all patients is abnormal in patient with Abystine anomaly. It may show tall and broad B waves as a result of right atrial enlargement, as well as complete or incomplete right bundle branch block. Complete heart block is rare in Abystine anomaly, but first degree AV block occur in more than 40% of the patient. Why? Because the right atrial enlargement and structural abnormalities of the atrioventricular conduction system. Correct identification and treatment of accessory pathway are essential and may help to prevent the patient from sudden cardiac death. Other investigation can be helpful in patients with Abystine anomaly is chest X-ray and cardiac cath. Cardiac cath, as we mentioned previously, is almost obviated by the echo. So diagnostic cardiac cath is rarely necessary in patients with Abystine anomaly, other than for preoperative coronary angiography assessment. So management of patient with Abystine anomaly consists of 3 parts: medical, catheter ablation, and surgical option. Medical, any patient with Abystine anomaly needs to be evaluated regularly by a cardiologist who has expertise in congenital heart disease. Prophylaxis for endocarditis is recommended despite its low risk in the anomaly. Physical activity recommendations are summarized by Task Force 1 on congenital heart disease. So if the patient is, this is for mainly for adolescents and adults, if the patient athletics with mild form of Abystine anomaly and nearly normal heart size and no arrhythmia, so those patients can participate in all sports. If patient athletics with severe Abystine anomaly, those patients are break-loaded from sports unless the anomaly has been optimally repaired, the heart size is nearly normal, and no history of arrhythmia exists. So patients with Abystine anomaly and heart failure who are not candidates for surgery are treated with a standard anti-failure medication, including diuretics and digoxin. Medical management of arrhythmia should be individualized and combined with operative or catheter-based intervention. For the second part, catheter ablation, electrophysiology study or evaluation and radiofrequency ablation of symptomatic accessory pathway should be performed when feasible in patients with Abystine anomaly who have tachyarrhythmia. Catheter ablation has a lower success rate in patients with anomaly than in those with a structural normal heart, and the risk of recurrence is also increased. Supraventricular tachyarrhythmia associated with the Abystine anomaly also can be ablated at the same time of operative repair. So for the surgical option, so this is like a history for the surgical option of the patient with Abystine anomaly. Starting in 1959, the repair of the tricuspid valve was reported in 2 patients who had Abystine anomaly. Both of them died. But the successful or the first successful operative intervention for regurgitation of the tricuspid valve in patients with this type of anomaly is described in 1962. At that time, the valve was replaced. And the initial publication on a patient with Abystine anomaly undergoing tricuspid valve replacement reported a surgical mortality of more than 50%. Also, similar high early mortality and unsatisfactory late results for tricuspid valve repair by the method that was available at that time also were reported or described. So then in between 1972 and 2005, my clinic conducted a study for 540 patients or consecutive patients with Abystine anomaly were operated at my clinic. The age at operation ranged from 2 months to 79 years with a median age of 20 years. Of those having a tricuspid valve procedure, valve reconstruction was possible in almost 34%, and valve replacement, usually they use bioprosthesis, was performed in almost 65%. There were 29 early deaths, so 5.4 mortality, early death. Late result of the first 323 operations have been reviewed, and there were 23 late deaths, almost 7.6%. during a follow-up extending up to 25 years. So their initial repair technique reported in 1979 consisted of plication of the free wall of the atrialized portion of the RV and posterior tricuspid annuloplasty and right reduction atrioplasty. So the repair is based on the construction of a monocuspid valve using the anterior leaflet, and their current repair usually involves bringing the anterior papillary muscle toward the ventricular septum. And this will facilitate the co-optation of the leading edge of the anterior leaflet with the ventricular septum. So this is an diagram showing the tricuspid valve repair technique. So starting with the first picture, or picture A, this is the anterior leaflet of the tricuspid valve. This is the posterior leaflet, and this is a septal leaflet, which is diminutive and only like a ridge of tissue. This is a two papillary muscle, and this is the chordae tendineae attached to the leading edge of the anterior leaflet. And this is the coronary sinus. This is a small BFO. So what they are doing, they are bringing the base of the two papillary muscle. So the base of each papillary muscle is moved toward the ventricular septum at the appropriate level with horizontal suture, horizontal matrix suture. And also the BFO is closed. So as we can see here, we brought both of the two papillary muscle toward the ventricular septum. So now in picture C, we brought both of papillary muscle toward the ventricular septum, and we also closed the BFO. Then at this level, this is the posterior angle of the tricuspid or tricuspid valve orifice. So this orifice, or the posterior orifice, or the posterior angle, is closed by bringing the right side of the anterior leaflets toward the septum and plicating the non-functional posterior leaflet in the same process. So this will be the result in picture A. So we close this posterior angle by bringing the right side of the leading edge of the anterior leaflet toward the ventricular septum, and we closed this angle. Then a posterior annuloplasty is performed. Why we do posterior annuloplasty? To narrow the diameter of the tricuspid annulus. So the coronary sinus here will be like a mark for the posterior annuloplasty, and it will mark the posterior and leftward extent of the annuloplasty. Then after the annuloplasty is done, picture F, annuloplasty is done, we will do an anterior pair-string annuloplasty. This is to further narrow the tricuspid valve annulus, and this annuloplasty stitch is tied over a 25 sizer or valve sizer. This is in adult to prevent tricuspid valve stenosis. And in the last picture G, this is a complete repair that's allowed the anterior leaflet to functioning as a monocuspid valve. So to summarize, the first, we bring the anterior leaflet by bringing the papillary muscle toward the ventricular septum. Then we closed the BFO. We closed the posterior angle of the anterior leaflet, and we did a posterior annuloplasty, and then anterior pair-string annuloplasty. So there is another technique which is described by Carpentier In 1988, Carpentier proposed a repair that used mobilization of the anterior lip of the tricuspid valve. This is for type P and C of Abystine anomaly, and temporary detachment of the anterior leaflet and adjacent part of the posterior leaflet was followed by longitudinal plication of the atrialized ventricle and the adjacent right atrium. And then he will do the repositioning of the anterior and posterior leaflet to cover the orifice at the normal level, and remodeling and reinforcement of the tricuspid annulus with a prosthetic ring. This repair was reported in 191 patients with a mean age 24 plus minus 500 years. And the early mortality rate was 9%, which is higher than in that study conducted in my clinic was almost 5%. And the mean late survival rate at 20 years was 82% plus minus 5. Another technique used for tricuspid valve repair is characterized by reintegration of the atrialized chamber into the RV cavity, which is called ventricularization. So this technique can be obtained by orthotopic transposition of the detached septal and posterior leaflet of the tricuspid valve. And the reimplanted septal leaflet serve as an opposing structure for coaptation of the reconstructed atrioventricular valve. Another technique, which is posterior annular plication. Posterior annular plication without plication of the atrialized RV, and prophylactic cavo-pulmonary connection are additional surgical option for non-neonatal Abystine anomaly, using the bidirectional cavo-pulmonary shunt when the RV is markedly dilated and with a poor function. This allows a reduced volume load on the RV, and it will improve the preload to the LV. The left atrial and pulmonary artery pressure must be low for the shunt to provide better hemodynamic benefits. So repair versus replacement, it has not been shown whether tricuspid valve repair replacement has better long-term outcome. One study has suggested that the valve repair is less durable in adults than in children. It is known that tricuspid valve procedures in Abystine anomaly have greater durability. So also another study in my clinic, a series of 294 patients with Abystine anomaly, the difference in freedom from reoperation at 12 years for tricuspid valve repair versus replacement and for fibrosthetic versus mechanical was not significant. So currently, preferable valve repair when visible over valve replacement, because repair has the potential of being more durable and also to avoid the potential complication of valve prosthesis. Some of their patients are doing well, free of reoperation more than 20 years after valve repair. They are generally prefer bioprosthesis over mechanical valve for Abystine anomaly, and reserving the later for those who are already taking anticoagulants for another indication. So this is a diagram showing the technique for tricuspid valve replacement in Abystine anomaly. We have, this is the first picture, okay? This is the tricuspid valve annulus, coronary sinus, AV node, membranous septum, and this is an interatrial communication closed with pericardial patch. So the valve suture line is placed on the atrial side of the membranous septum and AV node. So this is the AV node, membranous septum. The suture line will be on the atrial side to avoid an injury to the AV node or conduction system. And also the suture line is also deviated more cephalic to the tricuspid valve annulus, more posterolaterally, when if the tissue are thin and friable to injury. Why? To avoid injury to the RCA. If there is also sufficient distance between the coronary sinus and the AV node, so we can lift the coronary sinus on the atrial side by putting the suture line between the coronary sinus and the AV node. So in this picture B, the suture are tied while the heart are or is perfusing and beating. This is to ensure that the conduction system or the conduction rhythm is preserved. So antiarrhythmia procedure, although a decrease in an atrial tachyarrhythmia after standard repair of Abystine anomaly has generally been noted, it is preferred to combine repair with direct antiarrhythmic procedure. This can be accomplished without an increase in operative mortality and with freedom from arrhythmia recurrence in most patients with atrial flutter or fibrillation. And almost all patients with accessory pathway-mediated tachycardia or atrioventricular nodal re-entry tachycardia. Neonate with Abystine anomaly. Symptomatic neonate with Abystine anomaly have a poor prognosis, marked heart enlargement, advanced echoseverity gradient score, cyanosis, and severe regurgitation of the tricuspid valve. All of these are factors predicting the neonatal death without surgery. So biventricular repair in combination with correction of all associated cardiac defects are visible and midterm results are good. Conversion to a single ventricular repair or approach for symptomatic neonate also has been advocated. The result of tricuspid valve repair in young children have been reported and demonstrate low early mortality and good durability at late follow-up. So the last thing is take-home message. As we mentioned, the Abystine anomaly is a very complex congenital heart anomaly with a broad anatomical and clinical spectrum. The management will be complex and must be individualized. So precise knowledge about the different anatomic and hemodynamic variables, associated malformations, and management option is very, very crucial in this type of anomaly. It is important that patients with the Abystine anomaly be evaluated regularly by pediatric or congenital cardiologist. With a better management strategy, it is hoped that survival of patients with this anomaly of all ages will continue to improve. And thank you for your attention. Any question?
Thank you, Abdullah, for this presentation. Any question for Dr. Abdullah?
Yeah. Thank you for you. Go ahead.
I'm asking if there is any question for you. Dr. Khogir, do you have any comments or question?
So they describe in the literature the different techniques from Holland and from Hanover techniques, and of course, the thing that you should remember at your level is that neonatal Episteme, when the patient presents urgently or emergently in the neonatal period, it carries the highest mortality. Many people have reported mortality rates in the range of 50 to 60%. And the procedure then is totally different. It's called Sirens Procedure. I didn't hear you say or mention that. Later on, like most of the patients who present later in their young adult life, they may not, the majority may not require any repair if they have good function. And the three things that will push us for repair is the presence of cyanosis or arrhythmias or heart failure. And just like we said, the replacement of the valves carries very good prognosis, especially if it's done with good techniques avoiding the conduction tissue. Thank you very much for the presentation. It's very nice and comprehensive. And I would advise the group, whoever is interested, to read about the current literature on repairs. Thank you.
Thank you, Dr. Khugair.
Okay, can I make a comment? Ibrahim. Hi. Hello?
Yes, Dr. Ibrahim.
Thank you for this wonderful presentation. I would 100% agree with Dr. Khugair's comments that the neonatal group, especially if symptomatic, carries the highest risk in this, in any intervention. And I think that one consideration, one may be tempted in the neonate to consider a biventricular repair, but I think you have to do that with caution, because it really depends on, whether that right ventricle, which likely is not seeing, it's basically, pumping against free regurgitation in the tricuspid valve. So it's not going to be prepared likely to handle a full cardiac output if one were to make a competent valve in the tricuspid position, especially when they're that young. It might be, depending on how much of the right ventricle is atrialized and how much is a true ventricle, but still, I think one has to do this with, with caution. And in that regard, I think the Sirens procedure is something that is an alternative to, it's a single ventricle approach, but it may be something to consider more so, in my opinion, during the neonatal period when a child is symptomatic. But yeah, so I agree 100% with Dr. Khugair's comments.
Thank you to Dr. Ibrahim and Dr. Khugair for this comment. Thank you, Abdullah, again for this lecture. So for that, we'll have a break for 10 minutes, then we will start the next lecture with Dr. Ahmed.
Good. السلام عليكم.
وعليكم السلام. واضح صوتك دكتور احمد.
طيب يعني نبدا ان شاء الله. طيب شير سكرين. مسموع الصوت عبد الملك؟ السلام عليكم.
وعليكم السلام. واضح الصوت دكتور.
نبدا ان شاء الله. خلاص. السلام عليكم، حيا الله الجميع. انا معكم. ان شاء الله نبدا اليوم نتكلم على السنجل فنتريكل فيسيولوجي اند سيرجيكال مانجمنت ان شاء الله. So as we inshallah we start introduction. What is the definition of single ventricle? Single ventricle means it's not, there is no one lesion is called single ventricle. It's a variety of lesions that all these lesions, many variants of lesions that all this called the single ventricles. Single ventricle always refers to the physiology, not only the anatomy. Because the anatomy, you find many lesions, you have two ventricles. But at the end, the physiology is called single ventricle physiology. So it is a congenital cardiac malformations that lack two completely well-developed ventricles, and in which functionally there is only single ventricular chamber that supports both pulmonary and systemic circulations. And I have another definition, which is maybe more easier than this definition, that it's a variety of lesions that cannot undergo biventricular repair. Meaning that we, in normal circulations, we have two circulations in series in the normal human body. One systemic circulation that's supported by the left ventricle, supporting aorta, and pulmonary circulation is RV, giving pulmonary artery that's giving blood to the lungs. But if you have that means that this is like two ventricles, as a septum between each ventricle. So totally separate circulation that going in series. Like pulmonary circulation ends in the left atrium, left ventricle, it starts the systemic circulation, goes to the aorta, ends in the right atrium, the two circulation in series. But now in the single ventricle, meaning that we cannot separate the two ventricles to support two circulations. That we have, whatever we have, one ventricle, two ventricles, will support only the systemic circulation, which is the aorta, and the other ventricle, which is the RV, will be bypassed by a Glenn and Fontaine shunts. That's also, some people, they call this RV bypass circulation, RV bypass, that we are bypassing the function of the RV by putting a Glenn and Fontaine. And we'll know what Glenn and Fontaine later on. The Glenn and Fontaine, because we know the function of the RV is receiving the systemic unoxygenated blood, pumping this blood to the lungs to be oxygenated. So if we don't have one ventricle to do this job, so we'll do it directly by direct connection between the SVC and IVC. Instead of going to the heart, just direct communication between SVC and IVC to the pulmonary artery, bypassing the RV and leaving the other ventricle or two ventricles or whatever other ventricles to the systemic circulation supplying the aorta. So again, if we say that this is a definition again, it's a congenital cardiac malformations that lack two completely well-developed ventricles, and in which functionally there is one single ventricular chamber that supports both pulmonary and systemic circulation, but it means supports both circulation, but anatomically it will support only the aorta, and the other pulmonary artery will be supplied by the direct communication between the SVC and IVC to pulmonary artery. Or again, another definition are a variety of lesions that cannot undergo biventricular repair. That means that we cannot close the VSDs or ASCDs and to make two separate ventricles. And this variety of lesion, if we see in this one, this is a normal heart, have two atria, two ventricles, interventricular septum and interatrial septum are clear, separating the two separate red and yellow and blue circulations. This is a normal one. But if we have one big ventricle and one small ventricle. This meaning that this both will function as only one ventricle supplying the aorta, and the function of pulmonary artery will be supplied by the Glen and Fontaine that we later talk about. But whatever left ventricles, one big, one small, maybe the dominant one is right ventricle, sometimes the dominant one is LV, but both is called single ventricle. And we'll see what are the classifications of the single ventricle. As we know, we call the tricuspid valve or the mitral valve, they call the inlets of the valve. Yeah, the inlet of the LV is called the mitral valve, and the inlet of the RV is the tricuspid valve, and the outlet is the aorta in case of LV, and the pulmonary artery in case of RV. But so we have hearts with common inlet atrioventricular connections is called double inlet RV or double inlet LV, which is a more common double inlet LV, and we'll know that later on why double inlet LV is more common than double inlet RV. So the first type of the single ventricle anatomy is a heart with both AV valves, mitral and tricuspid, they open in one ventricle, which is more dominantly is the LV. So we call it double inlet LV. That means the RV is not receiving any blood. So whatever this ventricle, which is the LV, double inlet LV, will be a single ventricle because this small RV cannot support a pulmonary circulation alone. So this is called one variant of the single ventricle. This also cannot undergo biventricular repair because the RV is very small, cannot support complete pulmonary circulation. This is the first time. It's called double inlet LV, which is one ventricle having double inlet. It means two AV valves opening in this ventricle. And more due to embryological lesions, the LV is more common with double inlet. And also, the second type of the single ventricle subtypes is hearts with absence of one AV valves, atrioventricular connections, like tricuspid atresia or mitral atresia. Like just imagine, we'll see it now in one diagram, tricuspid atresia or mitral atresia. That means the mitral, if you have tricuspid atresia, and as we all know that every ventricle will follow, is the development of each ventricle will follow the development of its inlet. Like when you have the inlet valve is big, the LV, because this is like a gate door for this ventricle, if it is well developed mitral valve or tricuspid valve, the ventricle will follow development, good development or bad development according to this. So if we have absence or atresia of one valve, that means the following ventricle will be also atretic, non-functioning. So like also as a common form is called tricuspid atresia. So tricuspid atresia means the RV will be hypoplastic. Also the pulmonary artery will be hypoplastic. That means the all right-sided structures in the heart will be hypoplastic. So will be a one dominant RV, which is another variant of the single ventricle. So the first one is called double inlet LV. Second one, common one, is called tricuspid atresia. Also another one that another type of single ventricle anatomy is hearts with common AV valves and only one well-developed ventricle. That meaning what? Just imagine we have one AV canal type, like the two ventricles, two AV valves open in a well-developed ventricle, and the other one are very small. It's called the unbalanced AV canal. We know the balanced AV canal, when the left AV valve opens, overriding the left ventricle equally, like the RV equally overlying the RV. But sometimes it's called the unbalanced AV canal. I'll show you one picture now to make it easy now. And also the fourth type is called the hearts with only one developed ventricle. Like we have hypoplastic left heart syndrome. This is number 5, hypoplastic left heart syndrome. Also some lesions is called double outlet right ventricle and a ventricular septal defect removed from semilunar valves. Sometimes when we have a double outlet, as we see in the above, double inlet LV, we have also in the double outlet subtypes, but it's more common with the RV. Just imagine you have a double outlet RV, but the VECD is very remote to be tunneled to the aorta. So it's also called single ventricle. I'll show you now some pictures. Also, there is other rare types. We'll talk about it later. See this. Just a second. Yeah, this picture will summarize what we have said now. The first one here is called the double inlet one. When you have one ventricle, two AV valves opening in one ventricle. in the LV. So that means the other one, the RV, is very small, is non-functioning. So this is called double inlet LV, meaning the two AV valves, as shown here in this diagram, two AV valves opening in one ventricle. The second one, as we said, if we have atresia of one of the AV valves, like in this case, it's called tricuspid atresia. So if it is tricuspid atresia, meaning the ventricle following this tricuspid valve will be atretic. So we'll have tricuspid atresia and hypoplastic RV. So this is also another variant of the single ventricle, like this one, tricuspid atresia, and this is small hypoplastic RV. So whatever left in the LV is called single ventricle also. And also, this is a hypoplastic left heart syndrome. No, again, to go same sequence, this is the AV canal, unbalanced AV canal. This is AV canal when we have a one common AV valve and overlying one ventricle is big and one is small. When we have this septum is deviated to one ventricle and with dominant ventricle, we call this unbalanced AV canal. Because if we septate, that meaning we close this VECD, we have one big ventricle and one small ventricle that cannot, one can supply one circulation, the other one cannot supply the other circulation. We call it the unbalanced AV canal. Although this picture looks a little bit balanced, but actually the unbalanced is more, this septum is deviated either to the right side or to the left side. So having one dominant LV and one small hypoplastic RV, or the opposite. Sometimes it is pushed towards the left side, having a big dominant RV and smallish LV. The fourth common one is called the hypoplastic LV, hypoplastic left heart syndrome. That means all left side structures are hypoplastic, starting from the mitral valve, from the LV cavity. This is the ascending aorta, and this is they have only a big RV and big pulmonary artery, and ductus PDA, which is supplying, even the PDA is supplying the whole systemic circulation down to the descending aorta. Also, it supplies the retrograde, the coronary arteries. So the PDA that's coming from the RV through the pulmonary artery is supplying all systemic circulation. So this is another variant of the single ventricle. So again, we want to pass this slides, especially this slide, without really understanding this. Again, definition of single ventricle. Single ventricle, as we said, is not an anatomical term; it is a physiological term. But if we want to talk to the anatomy, single ventricle physiology meaning a variant of lesions, congenital heart disease, that cannot undergo biventricular repair, septating right and left, septating the heart, having a left-sided heart supporting aorta and right-sided heart supporting the pulmonary circulation. So it has many variants, either to be like double inlet LV, two AV valves sharing opening in the one ventricle. So that means we have the other RV is very small, not sharing, and they cannot support the pulmonary circulation. Or we have the tricuspid atresia, when we have this atresia in the tricuspid valve supporting a very small hypoplastic RV, cannot support the pulmonary circulation. Or we have this unbalanced AV canal, when we have a common AV valve opens in two ventricles, but one of them are small due to deviation of the interventricular septum, leaving one big ventricle and one small. So we cannot septate and make two equal ventricles. So this is also called the single ventricle, or also one of the most famous variants of the single ventricle, which is the hypoplastic left heart syndrome. When we know all left side structures are very hypoplastic, starting from the mitral valve, the left LV cavity, small ascending aorta, small arch that needs a single ventricle pathway, single ventricle physiology, and surgical ventricular pathway that we will talk later. So now the aim is at the end that to leave whatever big ventricle to support the aorta, and to bypass the RV function. Before we knew before that the RV function is what? Receiving the SVC blood and IVC blood to give it to pulmonary artery to the lungs. So if we can send this blood from the SVC and IVC to the pulmonary artery directly, bypassing the RV, that means we doing the job of the RV. That's why some people, they call it this single ventricle surgical management is called RV bypass surgery, by putting the Glen and Fontaine, Glen and IVC, which is Glen, which is a SVC to pulmonary artery, and IVC to the pulmonary artery, which is called the Fontaine to the pulmonary circulation, and bypassing the RV function and leaving whatever single ventricle, whatever RV, like in this case LV, or this case LV, or this case RV, we leave this ventricle to supplying the aorta, and the pulmonary circulation will be through the Glen and Fontaine. We'll talk about this later. But is this clear? Any question before we move forward to the more slides? Any questions?
No, so.
Okay, thank you. So now we have to classify also during according to. So now we talked more about the anatomy. Now double inlet LV or tricuspid atresia or hyplastic left heart syndrome or unbalanced AV canal. And we have also, we said in the classification, there are also other maybe there's many other lesions that's called a single ventricle. Like we will know later that if we have anything that causes very hyplastic one ventricle, it's called a single ventricle. Like we have, all the Abystine anomaly. Abystine anomaly means a severe displacement of the tricuspid leaflets down to the cavity of the RV. So if it is severe form of Abystine anomaly with a hyplastic RV, it's called also a single ventricle. It will be treated also by Glen and Fontaine. If we have something that we cannot septate, like sometimes cases of multiple VSDs that cannot be closed, also we cannot, if we cannot close them all, also this is, if it cannot be septated, we call this, can be also transferred to a single ventricle palliation. But if we want to talk about physiology now, because when the baby is born, the Glen can be done like at 6 months and the Fontaine around 3 years. But sometimes when they delivered, the physiology is different. Some of them have inadequate pulmonary circulation. Some of them have excessive pulmonary circulation, okay? And this one, excessive pulmonary circulation with systemic obstruction or without systemic obstruction, or we have a balanced pulmonary flow. Again, if we want to summarize in 3, we can say in the neonatal period, either they have inadequate pulmonary circulation, it means the blood flow going to the lung are inadequate, and the pulmonary blood flow is ductal dependent on the pulmonary circulation, or some of them have excessive pulmonary blood flow, and this is that meaning these patients will be having heart failure, like severe left to right shunt, or some of them have balanced in the neonatal period. So the management in the neonatal period will be dependent on this. As we said, all of these lesions at 6 months will have the Glen, and all at 3 years will have Fontaine. All these lesions before, like if we go backwards one slide here. So again, because this is a very important step. All of these lesions at 6 months of age will go Glen, and all of these lesions will go for 3 years will go Fontaine. But sometimes in the first presentation in neonatal period, they are varying in presentation according to physiology. Like I'll tell you what does it mean. All of you, I just want to tell you that all congenital heart disease either present by 2 things, either by excessive pulmonary blood flow. That means left to right shunt, the lung is receiving more blood than it needs. It's called heart failure group, like the VSD or any left to right shunts. It's called the heart failure group. And there's another group with inadequate pulmonary blood flow. This is called cyanotic group that needs something to increase the pulmonary blood flow, like anything with pulmonary stenosis or pulmonary atresia. This is general in pediatric cardiology and the neonatal presentation, either with excessive pulmonary blood flow or inadequate pulmonary blood flow, which is called cyanotic group. The excessive pulmonary blood flow is called the heart failure group, or there is another word called balanced. So I just want you to imagine one thing. Just imagine this case like this one. That's the high plastic left heart syndrome. Just imagine the RV is giving a huge pulmonary artery, giving blood to the both lungs, and the aorta, which is systemic circulation, only receiving blood from this ductus going this. So this one will have an excessive pulmonary blood flow. Okay, this one will have excessive pulmonary blood flow, and also like this one, like just imagine this one also. Just imagine unbalanced AV canal. You have a big RV supplying a big pulmonary artery, giving a lot of pulmonary blood flow to the lungs. This is called excessive pulmonary blood flow. It's called cyanotic group. This is called the heart failure group. This is a neonatal presentation. We call it excessive pulmonary blood flow. It needs a palliation in the neonatal periods called PE banding. We do PE banding. Or sometimes the opposite. Just imagine tricuspid atresia, like this one. You have hypoplastic RV, tricuspid atresia, hypoplastic RV, and sometimes it's coming with pulmonary atresia. So the lung is only dependent on PDA here. The PDA, that's why we call these lesions called ductal dependent pulmonary circulation. The ductal dependent pulmonary circulation, that means if this PDA closed, this patient will die because there is no pulmonary blood flow. So these lesions, we call them inadequate pulmonary blood flow. We call them the cyanotic group, or we call them the ductal dependent. So the initial neonatal palliation, they need shunt, because as we said, we cannot do the Glenn before 6 months, and we cannot do the Fontaine before 3 years. So the neonatal palliation depends on the first presentation. If we have excessive pulmonary blood flow, as we said in this one, if we have inadequate pulmonary blood flow, ductal dependent, so we'll need shunt. And before the shunt in the ICU, we can keep this PDA, we keep the ductal patency with prostaglandins, which is Prostin, until we do either PDA stent or BT shunt or central shunt, any systemic to pulmonary shunt. There's another group which is called excessive pulmonary circulation that we need to restrict this one by doing PE band in the neonatal palliation. Okay, and some of them is called balanced pulmonary blood flow. We just leave them, like, just for example, just imagine we have a lesion like this one, the unbalanced AV canal with big pulmonary artery, and also this baby delivered with pulmonary stenosis, as exactly as is banded from in utero, like unbalanced AV canal with dominant RV, giving excessive pulmonary blood flow to the lungs, and it has PS. So we call this lesion unbalanced AV canal with right ventricle dominance and PS. So it is exactly as is banded. PS, like native banding. Okay. So this patient, we call them balanced. We don't do anything in the neonatal palliation. So now we have to agree that all single ventricles, they at 6 months will have Glenn, at 3 months, at 3 years they will have Fontaine, but they all differ in the initial palliation in the neonatal period. If we have excessive, if we have this one, sorry. If we have inadequate pulmonary circulation, ductal dependent, so we have to keep the ductal patency initially in the ICU by Prostin, or by stent, or by putting a BT shunt. Sometimes the PDA is tortuous, or they cannot stent it in the pediatric cardiology cath lab. So they just send it to us as, and we do BT shunt or central shunt, any systemic to pulmonary shunt. And we said the third type is called the balanced group, that we leave them alone until 6 months, and we do. We'll talk later about the excessive pulmonary blood flow with systemic obstruction, with or without systemic obstruction later. Okay, so now we'll go the single ventricle, the initial management. If the medical management, if this ductal dependent, we give Prostin, as we said, ductal dependent, we give Prostin, and we have also, with this patient will have a metabolic acidosis, we have to give them, treat this acidosis, and treat also to maintain end-organ perfusion and function. We have to stabilize in the ICU before sending them to surgery. And if, as we said, if we have less or insufficient pulmonary blood flow, we have to put a shunt, or we have to put a band in cases of excessive pulmonary blood flow, or if it is balanced, we leave them alone. And the aim of the surgical intervention is to improve the natural history by balancing the blood flow between the pulmonary and systemic circulation, and ultimately separating these two circulations. As we said, either banding or shunt, we want them to reach, like the third type, the balanced one. If it is excessive pulmonary blood flow, we want to restrict the pulmonary blood flow by putting a band, or if it is inadequate pulmonary blood flow, we want to increase this pulmonary blood flow by putting a shunt. So we all agreed now at the neonatal palliation is putting, if it is all of them are going Glenn, 6 months, 3 years Fontan. Then the early neonatal palliation depends on if it is excessive pulmonary blood flow, we put a band. If it is inadequate pulmonary blood flow, ductal dependent, we put either a shunt or anything to keep the patency of the duct, either medical in the ICU before prostaglandins, or by cardiology, they can put a stent, or by us, we put a shunt, either central or any systemic to pulmonary shunt, BT shunt or central shunt. Or if it is excessive pulmonary blood flow, we do band, or if it is balanced, we leave it balanced, and to come later in 6 months, do the Glenn. This is the single palliation. In patients with decreased pulmonary blood flow, we put a shunt. Either this is modified MBT shunt, either we put it from the subclavian artery by Gore-Tex tube to the right pulmonary artery. This is in which type? The type was inadequate pulmonary blood flow. And sometimes we put it central between this aorta, the ascending aorta, and the main pulmonary artery. We put a central shunt like this. Central means from the aorta, ascending aorta directly. The BT shunt, modified BT shunt, if it is, we can put it, even we can do it from thoracotomy. We can do it here between the subclavian, and this is the modified one, which we use the Gore-Tex. Before, when it's first described by Blalik Tausig, it is they used to cut the subclavian artery from the arm and put it directly to the pulmonary artery, like this, from here to here. So this is the classic BT shunt. But later on, instead of it has a small incidence, a very low incidence of ischemia, but it's better just to put aside side-to-side anastomosis between side to end to side here to subclavian, and leave the patency of subclavian to the arm, and put it also into side here to the pulmonary artery, shunting the blood from systemic circulation to the pulmonary circulation. This is in cases of insufficient, inadequate pulmonary circulation. And this is a neonatal palliation, or sometimes we call it a stage 1 palliation. Stage 1 is called, this is the neonatal palliation. We all know stage 2, which is the Glenn, it's a Glenn for all. And stage 3, which is the Fontan, total cavopulmonary connection. This is stage 3 is the same for all. But they all vary in stage 1. In patients with insufficient pulmonary blood flow, we put the pulmonary atresia, pulmonary stenosis. When we have to put a shunt to keep the saturation between 75 to 80, because if we don't put a shunt, their saturation is less than 75. And also it's systemic to pulmonary arterial shunt, modified BT shunt. It's a graft between subclavian artery to the pulmonary artery. And the aim of this to improve the saturation. Because as I said, if you leave these patients alone, the PDA will close if you don't put prostatin, and they will desaturate down to 0 and they will die. So these patients should go to the ICU. That's why if any center in the anywhere in any hospital, even peripheral hospital, if they have any cyanosis, they feel any cyanosis, find any cyanosis to any neonate, they directly start the prostatin and send them to any tertiary center that they know is a ductal dependent. So they start prostatin, that means then they find saturation improving, and they send it to us, tertiary centers. Either we put stent for this pulmonary stenosis, or if it is atresia, we put a shunt, or they put a PDA stent. And also the second one, as we said, if we have excessive pulmonary blood flow, here the problem is not in the saturation. It's the opposite. Saturation will be more than good, maybe 100%, because these patients will have excessive pulmonary blood flow, then and they have a congestive heart failure manifestation. And this blood going to the lung, excessive blood going to the lung, is also returning back through the pulmonary vein to the single ventricle, they cause volume overload to the single ventricle. That's why they cause congestive heart failure. So to decrease this one, we have to decrease the pulmonary circulation. You know, we always call the pulmonary blood flow, we call the QP. QP means the blood going through the pulmonary artery. And the QS is called the blood going through the aorta, ascending aorta. So the lesions with excessive QP or excessive pulmonary flow, we have to restrict it by PE banding, that this is the initial palliation in the neonatal period, or stage 1 palliation for these lesions. We do PE banding, but this is in cases of there is no obstruction to systemic outflow. We said we'll talk about this later. But anyway, if we have excessive pulmonary blood flow, we'll do PE banding to treat the congestive heart failure. And the aim of this stage 1 palliation is to convert these patients to the balanced stage to reach 6 months, where we are able to do a Glenn shunt, which is stage 2 palliation. So now, there's 3 presentations in this single ventricle: either excessive pulmonary blood flow, they need band, or which is called excessive high QP. Excessive pulmonary blood flow means excessive QP. These need band, or the other one is the shunt. When this one is stage 1 palliation for cases when inadequate pulmonary blood flow, we have to do shunt. Or the third one is balanced situations, we leave them alone until they reach 6 months, and we'll go directly to stage 2 palliation. So stage 1 palliation, which is intervention before the Fontan circulation in patients with excessive pulmonary blood flow. This one, as we said, there is one with excessive pulmonary blood flow, but with obstructive systemic blood flow, we'll do the Norwood procedure, this is only for hypoplastic heart syndrome. We'll do something called the Norwood procedure and beat shunt. We'll talk about it later. I just want to leave this Norwood. We'll talk about it later, because this is only a situation for the hypoplastic left heart syndrome, which they have excessive pulmonary blood flow, but at the same time they have obstruction on the systemic flow, which is, as we said, the aorta is very small. So if we do banding alone, if we do banding, as we said before, this one, the hypoplastic left heart syndrome, this one, as we said, this is ascending aorta. Ascending aorta is very small, and the aortic valve is very small. And this one, if you classify this excessive pulmonary blood flow, if you're gonna do band here, but as we said, the systemic circulation is dependent on the ductal flow here. So if we do band, will also affect the systemic circulation. It's not only will stop the excessive pulmonary blood flow, we also will stop the systemic circulation. So we have to do something that's called DKS. We'll talk about it later, but I don't want to confuse now. Let us talk about the main presentations: excessive pulmonary blood flow and excessive pulmonary blood flow, or insufficient pulmonary blood flow that needs a shunt, and the excessive pulmonary blood flow that needs a band. We'll later talk about the hypoplastic, which is excessive pulmonary blood flow but have obstruction in the systemic circulation. We do DKS and Norwood. We'll talk about it later. But this is called the stage 1 palliation for the hypoplastic left heart syndrome. It's a special, this Norwood palliation, stage 1 is only a special stage 1 palliation for hypoplastic left heart syndrome. Anyway, when is the stage 2 palliation is necessary, which is the bidirection Glenn? We know the bidirection Glenn means what? Means the patient already have a stage 1 palliation, either by band or shunt or balanced left alone, or hypoplastic left heart syndrome that has Norwood. Okay, this is the Glenn. Wait, I just want to give you a picture for the Glenn. This is the Glenn. The Glenn, this is the upper half, only the Glenn. The hypoplastic left heart syndrome. No, this is the Glenn. The SVC is cut and only put on the pulmonary artery. This is the completion of the Fontan. The IVC is connected here. The SVC, which is the Glenn, is done in 6 months. The Fontan is done at 3 years. Again, we'll go back to the stage 2 palliation. Yeah, the stage 2. If you want to cut the SFC flow and put it directly to be drained, the SFC flow to go directly to the pulmonary artery. So there is no pumping effect to pump this blood from SFC to pulmonary. It's only working by gravity. So it has to have a lot of factors that might affect this flow. If you have, just imagine, you anything, there's many factors that might obstruct this flow because there is no, as we said, active force that pushing this blood. Only is passive by gravity. If you connect this SVC to the pulmonary artery, so we need a lot of factors to ensure that the good flow through from this gland, which is SVC, when we cut it from the right atrium and connect it on the pulmonary artery. That means, what are these factors? We need a mean pulmonary artery. You know, if these factors is present, that means you have a bad gland. If you have a high pulmonary pressure, more than 20, it's very high, the gland will fail because it's a venous blood going. If you have this, if the pressure is more than 20, the gland will fail. That means this pressure, we cannot go directly to this gland. We have to do something to reduce this pressure to make the ideal is 12 to 15. Also, the pulmonary vascular resistance, it has to be between 2 and 4. If you have more than 4, pulmonary vascular resistance, also this gland flow will be affected, and we should treat it with any vasodilators before we put the gland. Also, if these pulmonary arteries was repaired or augmented by patches or anything, we have to do angiogram to see if any deformities or any is not patent, like surgically patent, good shape, just good in shape, good in size, has to be also insured before we put this gland, because this venous blood goes passively by gravity to the pulmonary artery. If you have pressure high, if you have pulmonary vascular resistance high, more than 4 Woods units, or you have deformed pulmonary arteries by previous operations, repaired or augmented by patches or previous BT shunt, so it should be repaired also or augmented. Or we have also Magoon ratio. If you have Magoon, you know the Magoon ratio is the size of our right pulmonary artery and plus the size of the left pulmonary artery divided by the descending aorta at the level of the diaphragm. If it is 2, that means the pulmonary arteries are good size. So it means good for the gland. If you have also the LV in the stomach, the systolic volume is 2, but it's the mean in the systolic volume. If it is more than 12, it is really bad. The LV in the systolic pressure. If it is more than 12, it's really bad also for the gland pressure. And also when we do this gland with the target saturation of is around from 78 to 85. We cannot achieve 100% saturation by the gland, because if we put the gland, meaning the pulmonary, the QP only coming from the gland, which is the SVC draining the upper half of the body, and still the IVC blood is going to the single ventricle, going to the aorta. So unoxygenated blood going from IVC to the aorta will never have 100% after the gland. So the gland only bringing the upper half venous return unoxygenated blood to the pulmonary circulation. So, and still the IVC blood is going to the single ventricle, so we'll never have 100%. So accepted saturation 80, 85, 70, 80, 78 to 85% is acceptable. So the bidirectional, and why we call it bidirectional? Bidirectional because it is put on the confluence of the pulmonary artery that gives the right and left pulmonary arteries. That means it goes in bidirectional, because at the beginning when it's first described in the early days, it was prescribed that only SVC to the right pulmonary artery, and they disconnect the LPA from RPA, and they put shunt for the LPA. It's called, that's why the SVC was only directed to the one pulmonary artery. So before it's called unidirectional blood, but now it is put on the confluence of the above the right and left pulmonary artery, giving blood right and left. That's why called bidirectional cavopulmonary shunts. As bidirectional cavopulmonary shunt, which is a glen, is as a staging maneuver, usually combined with the repair of associated lesions, leading to poor outcome of Fontan. And also, as we have to know, this Glen is a preparation for the future third stage palliation. Fontan operation was the final one. So if we have any other lesion, at this time, we have to prepare it for the good Fontan. Like if we have pulmonary arterial stenosis, if we have AV valve, which is a mitral or tricuspid regurgitation, we have to repair it. If we have any systemic outflow tract obstruction, we have to repair it. Systemic outflow, that means any obstruction below the aortic valve. If any obstruction, we call it systemic outflow obstruction, systemic outflow tract obstruction. That means if we have any lesion that might affect the good Fontan stage 3, we have to repair it with stage 2, is the Glen. And most common one is the AV valve. If you have regurgitant AV valve, which is mitral or tricuspid, however, which one is dominant or both, if we have any one regurgitant, we have to repair it because we are preparing for the third stage palliation, which is the Fontan. So in this stage with the Glen, stage 2 palliation, we have to repair any lesion that might affect the Fontan circulation. And the aim of that, we have to reduce any volume overload on the single ventricle and maintain a viable saturation. That means if we have a valve regurgitation, it will cause a volume overload, and we have also any systemic outflow tract obstruction. Will add a pressure overload on the single ventricle. We have to repair any valve that causing volume overload or any obstruction that causes pressure overload on the single ventricle to be suitable for the stage 3 palliation, which is the Fontan, and also to preserve the ventricular function for the subsequent Fontan circulation. So now you understand that we are preparing the patient for stage 3 by stage 2 by doing the Glen, then and prepare the patient for stage 3. Also, one question that always you ask, or when we give this lecture, anyone asking, why don't we do the Glen and Fontan in one stage, in a stage like 6 months, we do Glen and Fontan. Why don't we put the SVC from above and the IVC from above? The question is to prevent sudden unloading of the ventricles. Like the ventricle single ventricle was receiving pulmonary blood flow, pulmonary venous return, and also systemic venous return from SVC and IVC, and suddenly you unload the ventricles, you always fail. So if somebody asks you, why don't we do the Glen and Fontan at the same time? We don't do that because to prevent sudden unloading of the single ventricle. But sometimes we do them before, when sometimes patients they present to us in an older age, like 10 years, 12 years. Sometimes we do something called primary Fontan, which is do Glen and Fontan one shot. But this nowadays there is no more this kind of patients with this with this recent good communications between hospitals, and all these patients are easily approached tertiary centers and the good referring system in the kingdom. There's no more now. We used to have these cases maybe in the last decade, patients not palliated in the first in the neonatal period and the 6 months, 3 months. But we used to have something called primary Fontan on late presentation single ventricle. We can use Glen and Fontan at the same time. But now we don't do this. We have to do Glen stage 2 at 6 months. And during this Glen circulation, we prepare them for a Fontan. If we have this single ventricle have any volume overload in terms in the form of AV valve regurgitation, we have to repair it with the Glen, or we have systemic flow outflow tract obstruction, which causes pressure overload. We have to also treat it before, as we said here in the last one, to preserve the ventricular function for the subsequent Fontan operations, which is. And the Glen, as we say, it's an end-to-side connection between cranial end of SVC and the right pulmonary artery. This is the description of the Glen. And also we ligate the azygos vein, because the azygos, as we know, opens on the posteromedial aspect of the SVC. We have to ligate it for 2 reasons. One of them is to give mobility for the SVC to put it on the right pulmonary artery. And the second one also not to steal blood down to the from SCVC. The aim of Glenn that we direct the unoxygenated blood to the pulmonary circulation. But if we leave the azygos open, it might receive blood, escape blood from this azygos, go back down, and have sometimes anastomosis connection collaterals with the IVC. So return this blood unoxygenated to the IVC to the heart again. So is act as a collateral that will cause desaturation, because we want to force the upper half drainage of the body unoxygenated blood through the SCVC totally to the pulmonary circulation to be oxygenated. If we have in some cases bilateral SCVC, as you all know, sometimes you have a bilateral left SCVC and right SCVC. Both should be connected to the respective pulmonary arteries, like we do bilateral Glenn. So bilateral Glenn means what? One right Glenn and one left Glenn in cases of you have bilateral SCVC. So bilateral is different term than bidirectional. We say bidirectional if you have one SCVC is directed to the confluence of pulmonary artery giving right and left. But sometimes if you have two SCVC in cases persistent left SCVC, so we anastomose each SCVC to the corresponding pulmonary artery. It's called bilateral Glens. So bilateral Glenn term is different than bidirectional Glenn term. Bilateral Glenn term in case of persistent left SCVC. The cavity pulmonary shunt, which is Glenn, increases effective pulmonary blood flow without volume loading of the ventricle. The systemic venous collateralization may worsen the hypoxemia by reducing the effective pulmonary blood flow. As I told you, there is something called collaterals. If you have any collaterals blood from SCVC to the down to the with the SCVC to the IVC, it's called collaterals. As we said, if you leave the azygos, it will act as a collateral. Blood, instead of going to the effective pulmonary blood flow that going from the Glenn, unoxygenated blood in the Glenn SCVC to the lungs, will escape to these collaterals, which is called the veno-venous collaterals. So the collaterals with the IVC will go back to the IVC, vena cava, to reach heart again. So this will cause desaturation because the blood, instead of going to the lung, will go down to the IVC to the heart. So this will cause significant desaturation. So by cath, if we have any collateral, they should close it, or we close the azygos vein, as we said here. We ligate the azygos for two reasons: to prevent the collateral effect, veno-venous collaterals, and cause desaturation. Plus, also it gives the mobility to the SCVC to be anastomosed to the right pulmonary artery. There is concerns about the growth of the pulmonary arteries. They said the Glenn itself sometimes, because the flow is only venous, sometimes doesn't cause pulmonary artery to grow. But reality is they grow normally. The pulmonary arterial fistula may be a universal consequence of bidirectional cavity pulmonary shunt. The pulmonary arteriovenous fistula, this means this is one of the malignant complications sometimes of pulmonary of the Glenn, because there is a theory saying when the lung needs something that's called the hepatic factors that comes directly from the liver through the IVC to the lungs. This prevent development of AV malformations, arteriovenous fistulas. So when you put a Glenn, only the blood going to the lungs, only coming from the upper half of the body, doesn't have the hepatic factors that comes from the liver. So sometimes it is a serious complication if we delay the onset of the fontan. We might have something called AV malformations due to the absence of the hepatic factor going to the lung, which is coming through the hepatic veins to the IVC. But now during the Glenn period, the lungs does not receiving any hepatic factor. So that's why we usually try to not to delay the fontan beyond 3 years. Even some centers all over the world, they went down to 1.5 years to do the fontan. So delaying the fontan is not good. Yes, sorry. Yeah. Also, left ventricular mass in younger. Yeah, this also the Glenn. When you unload the ventricle with time, it will cause the regression of left ventricular mass in younger children, improvement in the degree of atrioventricular valve regurgitation. This also well observed when you do a Glenn. If you have moderate AV valve regurgitation, when you take this flow from SCVC from the single ventricle, you found improvement in the left AV valve regurgitation, improving the volume overload. So, and now we come to, this is the Glenn, as we see here. This is the Glenn. SCVC is connected to the pulmonary artery. And if we have azygos here, we cut it. And this is this one. And you see, as you see here, if you cover this pulmonary, if you cover this fontan one, if you cover this fontan, it's only Glenn, you find out the pulmonary, the lungs are not receiving any blood from IVC. So this is a hepatic factor that might cause absence of hepatic factor to the lungs, might cause AV malformation. Anyway, we go now, patient has finished the Glenn and coming to us at 3 years of age, and he wants to have the fontan, which is the stage 3 palliation, which is the more common now. We connect the SCVC, the IVC by extracardiac tube. It's called extracardiac fontan. Before we used to do this intraatrial buffle between the IVC to the pulmonary artery from inside the pulmonary artery, like this. It's called intraatrial buffle, not disconnecting the IVC. Just we leave the IVC inside the connection to the atrium, but from inside the atrium, we do a buffle from inside the atrium to the pulmonary artery. But nowadays we do more extracardiac fontan like this. We use cortex tube, size 18 or size 20, to we transect the IVC from the right atrium and connect the tube between the IVC to the pulmonary artery, especially exactly the right pulmonary artery under the Glenn. So now we call it TCPC, total CAVU, both cava, SVC, and IVC to the pulmonary. TCPC means total CAVU pulmonary connection. Total CAVU pulmonary connection, TCPC. And as I told you, nowadays we go more, is the extracardiac fontan more than the atrial buffle here, because the atrial buffle complications mainly because it's inside the atrium. Mainly it has more complication by atrial rhythm. You have arrhythmias, which is a very malignant to the fontan circulation. Any arrhythmia is very malignant to the fontan circulation. So we avoid all this. We just disconnect the IVC from here and connect it to the pulmonary circulation by extracardiac tube, cortex tube. It's called extracardiac fontan. This is extracardiac fontan. And sometimes we do just a small hole between the fontan tube to the right atrium, which is called the fenestration. This fenestration, it's just like if the fontan pressure increases, it just gives away a blood to here. Because as we will talk now about the fontan requirements, we need a low pressure in the pulmonary artery. If it's high, if any time this pressure in the lung gets high to any reason, so we leave this fenestration to avoid the back pressure. Because just imagine the fontan circulation is getting high, so the IVC pressure will be high, then the patient will have ascites, edema, and also the Glenn will have puffy face, puffy neck. So if the pressure is getting high to any reason, chest infection, pleural effusion, whatever, so to have a vent from here is called fenestration. We don't do this fenestration except only if we have a preoperative high pulmonary artery pressure. So now we reach the stage 3 palliation, which is called the fontan. As I told you, 2 types. This is intraatrial buffle, and it's not commonly used now. Now the most common used is the extracardiac fontan using a cortex tube, and sometimes we do in 25% of cases we do fenestration according to the pressure. If the pressure of the pulmonary artery is high, we do fenestration. This is the extracardiac fontan. As we see here, this one is a fontan. This is the intracardiac buffle to drain all the systemic veins direct to the pulmonary artery, preserving the functioning single ventricle for the systemic circulation. As I said, After we complete this Fontan circulation, that means no systemic venous blood going to the single ventricle, only pulmonary blood flow. So whatever the single ventricle is, LV dominant, RV dominant, whatever, it will only supply the aorta, which is the systemic circulation. That's why, as I told you at the beginning, this Fontan circulation is called, as some people label it as a RV bypass. RV bypass procedure, because we bypass the function of the RV, which is receiving the blood from SVC and SVC and IVC, pump it to the lungs, so pulmonary artery. Now, no more RV function here. Whatever whatever ventricle left will act as a systemic ventricle, supplying only aorta, and the RV function is supplied now directly by the Glen and the Fontan connection from IVC to the pulmonary artery. So it's a very important question now. How can we prepare the patient for Fontan? Like now, patient having Glen, as we mentioned before, the Glen has a preoperative preparation. As we said, we need a good pressure, 12 to 15. We need good end-diastolic volume. We have good pulmonary artery size and shape, not distorted by previous operations. Also, Fontan has more requirements. The goal before proceeding to the Fontan circulation, appropriately regulating the pulmonary blood flow since a newborn period. We said, as improving clinical symptoms, cyanosis or congenital heart failure, provide optimal pulmonary artery architecture, size and shape, and no pulmonary vascular resistance, preserve systolic and diastolic ventricular function, preserve atrioventricular valve function, relieve any systemic ventricular outflow tract obstruction. As we said, AV valve regurgitation, this is a volume overload. Systemic outflow tract obstruction is a pressure overload to the single ventricle. We have to relieve all of this before the Fontan, provide anatomic setup for a definitive Fontan repair. So an ideal saturation before the Fontan 80%, which is because the patient is only dependent on the Glen. But after Fontan, the Fontan circulation has to be, the saturation has to be like normal, because all the pulmonary blood flow, now all systemic unoxygenated blood is going through SVC, IVC to the pulmonary, to the lungs. So as before, it was very famous, it's called the 10 commandments for Fontan. As we say, the Al-Wasaya Al-Ashr before Fontan. This 10 commandments, it's amended now by different, before they thought that the age is appropriate between 4 and 15 years. Now is 3 years. And they said also presence of sinus rhythm, normal systemic venous return, no right atrial, normal right atrial volume, mean pulmonary artery pressure equal or less than 15. Pulmonary, the PVR is less than 2 Woods units. Ratio of pulmonary artery diameter to the aorta diameter more than 75 means the pulmonary size is good, as we say. And also left ventricular function is normal, more than 60%. Competent AV valves, no adverse effect from prior pulmonary operation. If we want to summarize these ones, we summarize it in a different way. I like to summarize it in a different way. If we say like this, I will summarize like this also. Graham and Jones pointed that the following issues criteria were not included in the 10 commandments. The diastolic dysfunction, which is the single ventricle EDP, should be less than 12. Also, they didn't comment on this 10 commandments about the ventricular hypertrophy, the systemic outflow obstruction, the right ventricular type of the single ventricle, because some people, they say if the dominant ventricle is right ventricle, it's worse for the outcome and prognosis of the single ventricle. But if the dominant ventricle is left-sided, it is more favorable outcome. If the single ventricle is the LV type, not RV type. Also, extensive systemic aortopulmonary collaterals. They said all these things are not present in the 10 commandments. And also, one of the things that changed from this 10 commandments from before they said the optimal age is 4 to 15, but now it's 3 years. Even as I told you, some centers go down to 1.5 years. And also, if I summarize it, I just want you to imagine this picture with me. Wait just a second. Yeah. If this is the fontan, this is a fontan circulation. The fontan now gives the blood to the pulmonary arteries, and the pulmonary arteries give the lung here. So if we go one by one, the fontan blood goes to the pulmonary arteries, to the lungs, and be drained again to the pulmonary veins, to the single ventricle, to the aorta here. So if you ask me, if you want, imagine with me now the trip or the journey of the blood going from the fontan to the pulmonary arteries, right, to the left lung and right lung, then be drained again to the pulmonary veins, to the left atrium, to the single ventricle by either tricuspid valve or mitral valve, and goes to the aorta, to the systemic circulation, the blood. If we go to this journey step by step, if you want to go, if somebody asks you what is the favorable conditions or what is the best preparation or what is the factors that might affect the fontan circulation, we can say first factors in the pulmonary artery itself, factors in the lungs, factors in the ventricle, factors in the patient. Let us follow the journey again. We need a good pressure here, as we said before, 12-15 pulmonary artery pressure to be favorable. 12 to 15, above 20 is contraindicated to the fontan. But pressure has to be good pressure, low pressure, size of the pulmonary artery, good size, not distorted by any operations, and good shape. And good size and good shape. As we said, by Magon ratio has to be 2, or by shape also has not to be distorted by any previous operations, by augmentation. And if we go to the lungs, we need from the lung, the pulmonary vascular resistance from the lung, not to exceed 2 to 4, less than 2 is perfect, 2 to 4 acceptable, above 4 is high and need to be treated first by vasodilators. And if we go, again, the journey of the blood from the fontan to the pulmonary artery first. We said first in the pulmonary artery, we need good pressure. 12 to 15 is the best, 15 to 18 borderline, above that is really high. Above 20 is contraindicated, but if it is high, we need to treat it first by dilators. So pressure in the pulmonary artery, also size and shape has to be good. The lungs, then the blood will go to the lungs. We said in the lungs, the main factor in the lung has to have pulmonary vascular resistance not to exceed 4. The best below 2 to 4 is acceptable, Wood's unit. Then the blood will come later to the left single ventricle through the left atrium to the single AV valve. If the single AV valve is regurgitant, having volume overload on this single ventricle also will affect the fontan circulation, because after doing the fontan circulation, the blood will go only 2 circulation in series. Unoxygenated blood will go from Glen and fontan to the lungs, back to the left atrium, to the lung, to the single ventricle, to the aorta. Anything will obstruct this pathway will affect the fontan circulation. So we said pulmonary artery pressure, pulmonary artery size and shape, pulmonary vascular resistance. If we go to the AV valves, if any regurgitation has to be repaired during the Glen operation, because this will affect volume overload on the single ventricle. If we have also any obstruction, systemic outflow obstruction, any subaortic stenosis will cause pressure overload in front of the single ventricle. This also has to be repaired before the fontan. If any of the function is poor, ejection fraction less than 60%, which is the systolic function. We said the systolic function has to be good, meaning ejection fraction has to be 60% and more. And also the diastolic function has to be good, meaning that the end diastolic pressure EBP has to be not more than 12. And also no arrhythmia. Sinus rhythm is the best for fontan. Any arrhythmia is very malignant to the fontan. And things in the patient itself, if he has anything that might affect his respiratory capacity, like kyphoscoliosis or any skeletal deformities, also might affect the blood flow in the fontan and might cause the fontan to fail earlier. Again, I really want to repeat this again, because this is the main important factors that anyone can ask you for this. If somebody will ask you about single ventricle, might ask you about classification, might ask you about definition, might ask you about the staging, what's the neonatal staging, either banding or shunt or balanced, you leave it alone, or second palliation glen, third palliation fontan, then the most important questions, they will ask you what is the best criteria to have a fontan, or he will ask you what is the preoperative assessment before fontan, because we do cath to assess before fontan, or he might ask you the question the other way around. He might ask you what factors that might cause early failure of fontan, or might ask you if you are a fellow and you in the pediatric cardiac surgery department and you have tomorrow a case of a fontan, what things you should really assess and confirm before having the patient to OR to have fontan. You tell him, if you summarize it, or if you keep it in mind in this way, I feel this is my way, I like it to say it this way. If we imagine this a fontan circulation will pass this journey, pulmonary arteries, then go to the lungs, right lung and left lung, then go back to the pulmonary, to the common atrium, either left or right atrium, by pulmonary venous drainage to the single ventricle to the aorta. So this journey will be affected by, first of all, the pulmonary artery pressure. We said the best pressure is 12 to 15 millimeter mercury, and also the pulmonary artery has to have a good size, good shape, not to be distorted by any previous operations, plus things in the lungs. The PVR has to be 2 to 4 maximum. Less than 2 is perfect, more than 4 is contraindicated. And also things in the ventricle, single ventricle, not to have volume overload in terms of AV valve regurgitation. An AV valve, whatever, maybe tricuspid in case of dominant RV, or maybe mitral in case of LV dominant, or maybe cases on double inlet LV, maybe mitral or tricuspid, anyone. But anyway, that's why we call them AV valve, the right AV valve or left AV valve in single ventricle. So we said good left ventricular function, devoid of volume overload in cases of AV valve regurgitation, no pressure overload for the single ventricle in terms of subaortic obstruction, good systolic function in terms of good ejection fraction, more than 60, good diastolic function in terms of EDP has to be less than 12, and also no arrhythmia, which is very bad malignant to the fontan circulation. And also the patient has to have no skeletal deformities that might affect the respiratory capacity, and might, as we said, this is the pressure, the flow will go to the lungs. If the lung has any things that might impair the respiratory functions and respiratory dynamics, might affect also the fontan flow. Back to our slides. So if you summarize all what I said, it will be these things plus the 10 commandments, plus the age. We said now preferably 3 years. The necessary criteria: unobstructed pulmonary blood flow anatomy, pulmonary artery anatomy. This also summarizing what I have said, but in a different way. Low pulmonary vascular resistance, low ventricular end diastolic pressure less than 12, absence of obstruction of systemic outflow, which is in terms of sub-AS, preservation of systemic atrioventricular valve functions. If again, unobstructed pulmonary blood flow, pulmonary artery anatomy. That means unobstructed means good pressure, good size and shape, low pulmonary vascular resistance in the lungs, no PVR should be 2 to 4 maximum, low ventricular end diastolic pressure maximum 12, absence of obstruction, systemic outflow tract, no sub-AS, and preservation of systemic AV valves, no regurgitation that causes volume overload, and this obstruction to systemic outflow causes pressure overload in the single ventricle. The method, either the lateral tunnel technique, involves placement of the buffer along the lateral aspect of the right atrium, which conveys IVC blood to the SCVC orifice. Sometimes we cause also sometimes 4 millimeter fenestration by the punch, like the one that you do the proximal anastomosis in CABG. We do a fenestration 4 millimeter in the medial aspect of the buffer to prevent systemic venous pressure rising to intolerable limit. It means like a venting. Large ESD is created to prevent any restriction of flow between the atria, like means septectomy between the two atria. But this is, as I told you, the lateral tunnel is not more used nowadays, always to preserve systemic cardiac output at the expense of some reduction in arterial saturation. This fenestration, it might cause some desaturation, but it will be very beneficial in case of high pulmonary pressure. Lower operative mortality, and also, but they have some pleural effusion post-operative. post-operative management. If you have a case of a Fontan, you have to do all things to minimize the pulmonary vascular resistance by means of any pulmonary vasodilators, melatonin, any dilators, even nitric oxide sometimes. Monitor systemic and pulmonary pressure and the indicators of good cardiac output as good pulses, urine output, blood pressure, also CRT, and systemic venous hypertension leading to reflex arterial constriction lead to increased afterload, might impair the cardiac output. So we have to use melatonin and nitric oxide. That means anything that causes systemic venous hypertension, we have to treat it by dilators. Any arrhythmias, we have to use to fix it by atrial pacing, because lowers the atrial filling pressures and augments the cardiac output. Pleural effusions and ascites, we have to drain it because this also might affect. If you have pleural effusions, it will affect the lung and consequently will affect the Fontan circulation. The outcome: early mortality 7.7%, late mortality, survival 93% at 5 years, 90% at 10 years, 91%. Most common causes of death: thromboembolism in intracardiac thrombus or lack of aspirin or warfarin, heart failure due to morphological RV, if it is a dominant single ventricles RV morphology, or high right atrial pressure, protein losing enteropathy. It's a common complication after Fontan. We'll talk about it later. It's some sort of ascites or like ascites. It's like some sort of ascites. As we all know, if the IVC facing a high pressure, it will drain in the abdomen, especially it will have some sort of proteins called protein losing enteropathy. We'll talk about it later. Or sudden death due to cardiac arrhythmia within first 5 years after Fontan surgery. As I told you, any cardiac arrhythmia is very malignant to Fontan. So one of the commandments also for a good Fontan is the patient's sinus rhythm. Sinus rhythm is very crucial and essential for the Fontan circulation to work properly. Any arrhythmia, it might induce sudden death in case of Fontan and cause early death within 5 years of post-Fontan. There are also complications of the Fontan: early complications, pleural effusions, pericardial effusions, sternal wound infections, arrhythmias, stroke. You know, the effusions is very common because for sure the IVC blood before the Fontan was received by the atrium pump to the aorta by ventricle. But now when we connect to the pulmonary artery directly, there is no pump in the middle. So any factors that might increase the pulmonary pressure or pulmonary vascular resistance will affect negatively on the pulmonary and the Fontan circulation, will cause pleural effusions or pericardial effusions. Also late complications like atrial arrhythmias, ventricular dysfunction, protein losing enteropathy, thromboembolic events due to this extracardiac Fontan tube. The atrial arrhythmia, major risk for morbidity and functional decline after the Fontan procedure, especially in the type of the atrial buffle. It is the atrial arrhythmia is more common in the atrial buffle, not in the extracardiac Fontan. That's why now almost most of the center, or not almost all of the centers, move to the extracardiac Fontan, less complications, less atrial arrhythmia, because it's 10 to 40% in the atrial buffle Fontan. Most common sinus node dysfunction, sinus node injury while redo, or disturbance for its blood supply. You know, when we do, we might injure this blood supply with the sinus node, or sometimes due to the gland itself, when we disconnect the right atrium from the disconnect the SVC from the right atrium. If you cut it very low down to the right atrium, you might injure the sinus node artery, cause sinus node dysfunction, and it will have a negative effect on the Fontan circulation later, or Fontan physiology. The cause right atrial dilatation or any right atrial incisions. Also treatment is anticoagulation if refractory. The protein losing enteropathy, one of the complications of the Fontan is that if the patient is developing protein losing enteropathy, is a very poor prognosis. The 5-year survival is 59%, 10-year survival is only less than 20. The incidence of protein losing enteropathy is 3.8 to 10%. It is a lymphatic drainage dysfunction The treatment is anticongestive therapy, steroids, heparin, atrial, do also fenestration to the fontan, or heart transplant. As I told you, if we don't follow the good criteria of fontan, low pressure, good size, low PVR, good function, no arrhythmia, you don't have all these complications, protein loading enteropathy. Most of the complications of the fontan is due to bad selections, and bad selections meaning that all these factors, commandments that we said we have to follow and fulfill, if are not fulfilled fully, you will have complications early, and you have a very bad fontan complications. One of the most serious is called the protein losing enteropathy. Very serious complication that might need heart transplant. Also, ventricular dysfunction and heart failure, 8.3%, preload reduced to 57% of normal for blood surface area. This is because we took the preload, as I told you, remember when I said, if somebody asked, why don't we do ghrelin and fontan at the same time? We said sudden preloading of the heart might cause failure. Also, after the fontan, the preload of the heart is reduced significantly because you took the IVC and the SFC blood and put them to the pulmonary circulation directly. So the preload to the heart is reduced. So sometimes cause heart failure. Also, ventricle from volume overload to overstretched to severely unloaded. When we unload the heart by the fontan, might cause diffuse hyperfunction. And anyway, it's a very bad kind of heart failure that needed heart transplant. And we might know if the heart transplant is not available, sometimes we do late takedown. And we take down the fontan again, we take the IVC and put it on the heart again, the IVC, and we put central shunt to the, either we take down the fontan or we put a big fenestration to the heart until the transplant is ready. But if we put it again back, the patient will desaturate significantly. It will be desaturated because you put again the SVC unsaturated blood to the heart. But we has to be combined with something called central shunt. But this is a very bad situation. The only treatment, if available, is the transplant. Also, right atriomegaly and the hepatic dysfunction. This is also one of the complications. Dilatation of the coronary sinus, pulmonary AV malformations, myocardial dysfunction and failure, ventricular outflow obstruction. All these complications of the fontan. Also, something is called plastic bronchitis. This is also one of the forms that you find this white cast inside the bronchial tree, and the patient coughs like a cast, white cast, like with the shape of the internal shape of the pulmonary the lung bronchi. It's called the plastic bronchitis. It also is one malignant course. If it happens, that means the fontan is failing, and you are going in the failing fontan pathway. That the only treatment is lung, and if you have plastic bronchitis, that you might need heart-lung transplantation. Also pancreatitis, because this is all any abdominal complication due to abnormal drainage. The IVC before was giving the blood to the heart, pumping. There is a pump in the middle, but now when you put it direct to the artery, there is no pump. So there is a stagnation, especially if there is any reasons that increase the pulmonary pressure or pulmonary vascular resistance. So the defective venous return might cause pancreatitis or bronchitis or systemic venous collateralization. Also WBW syndrome in the atrium. Thank you, and I wish that you got the new information, and I'm happy for any questions. I'm ready for any questions.
Dr. Alwi, thank you for the comprehensive review. I just have two small questions. First one, you said that we don't do the glen and fontan together because we don't want to unload suddenly. Yeah. So isn't it also to protect the lungs? This is the first question. Second one, can we call bilateral bidirectional glen Kawashima also?
Okay. The first question is, you protect the lung from what? Is not usually we protect the lung if we have excessive pulmonary blood flow. We put a band because there is a big flow coming from both ventricles to big pulmonary arteries to both lungs. But if we put this, the lung is always ready to receive equal amount total cardiac output. The lungs, both lungs, are ready to receive total output. So if we put SVC and IVC, this is a total output, no more than QP or QS. Like this is normal QP for the patient. But the lung is not, the proof for that, in cases of neonatal palliation of reduced pulmonary blood flow, we put a shunt. You know the shunt, the BT shunt or central shunt is having a higher blood than the glen, and the lung is accommodating. So it's not due to that. The only reason for that is to prevent the sudden unloading of the ventricle, because a ventricle that receiving SVC, IVC, pulmonary veins, suddenly when you take the SVC and IVC blood, sudden unloading causes failure. Okay, like a hemorrhagic shock. Why sometimes the heart, when really suddenly hypovolemia can cause heart to arrest and fail, because a sudden unloading of the heart causes this is has an explanation on the myocardial level and the myocyte level. But the other question, Kawashima, is totally different issue. It is also a glen, but in case there is one special scenario when the IVC is not reaching the right atrium, it is interrupted IVC. When it's interrupted IVC and interrupted IVC, and the IVC flow will be continuous with the hemiascus in the left side, then drains in the SVC. We call this interrupted IVC with a hemiascus continuation. Interrupted IVC with hemiascus continuation, okay? The interrupted IVC with hemiascus continuation. So when we do the glen this time, it will be having the SVC blood and the IVC blood, because the IVC blood reaches the SVC blood through the hemiascus continuation. So the glen in this situation is called Kawashima. The guy described the glen in this situation is called Kawashima. So the glen in this time, it is like a glen and partially Fontaine, but we don't do it. That's why we don't do it in an earlier age. We do it always like Kawashima. We do it in a later age, like 1.5 years, 2 years, because it's almost 3/4 of Fontaine. Because I wish that we can have just a second. It's a very important question, but it is I didn't mention it because it is a very rare situation. Just a second. I wish that. Yeah, if we go like this one, I wish that we this situation maybe here. Yeah, the interruption. The interrupted IVC. I wish that I can find an image for that because it's really. But are you with me now? What's meant by interrupted IVC with hemiascus continuation? That means the IVC blood will go to the will end in a hemiazygous to the hemiazygous to the SVC. So when we do the glen is not only receiving the SVC blood, will be also receiving the IVC blood through the hemiazygous. So the one described it's called Kawashima. That's why I call this glen is like a glen and partial Fontaine. But the hepatic veins still draining in the heart. It will later need another. Yeah, maybe this picture. See this picture here. Are you following me now?
Yes, doctor.
This is the IVC here. This is the IVC. the IVC blood. Okay, this is the IVC blood. And instead of going, did you hear in this one, the IVC, instead of going to its place in the right atrium, we call IVC interruption, interrupted IVC. So the IVC blood goes upwards with the hemiazygos and drains in the left SVC. So in the time when we do the glen, which is SVC, to the pulmonary artery, it will receive only, it not only receive the SVC, it will also receive the IVC blood with the as a hemiazygos continuation. So it is called, this is a normal glen. Is for us, technically, it is like a glen, but it's also carrying the SVC blood and IVC blood. That's why called the Kawashima. But this is not all the venous return, because there is also the hepatic veins from the liver here still draining in the left atrium. So we do something later on instead of the fontan. The first stage is called, the second stage is called Kawashima, which is a normal glen, but glen was receiving the SVC blood and IVC blood. But later we also divert the hepatic veins blood to the pulmonary artery to complete, we call it hepatic completion of after Kawashima. To complete the unoxygenated blood to go to the pulmonary artery direct. Okay?
Thank you, Dr. Ali.
Very good question. Thank you. It's a very nice question. Okay, yeah, see this picture? See this picture is very, very important. This is IVC. IVC is disconnected. It's not going to the right atrium. So this with the azygos vein joining the SVC. So when we do glen by this SVC, it will not only carrying SVC blood alone, it will be carrying the IVC. But later on, we have to, this unoxygenated blood from the hepatic veins going to the right atrium single ventricle will cause desaturation. So at a later stage, we do something that's called hepatic completion. We cut this one and put extracardiac tube to the pulmonary artery. That's why we call it hepatic completion after Kawashima operation. Okay, any more question? Any more question?
Thank you, Dr. Alwa. I believe no other questions.
Thank you very much. حياكم الله وشكرا جدا، واي سؤال اي شيء انا تحت الامر، وان شاء الله I will share this presentation on the group, and any questions you can contact me anytime. My number was Dr. Abdul Malik, was Dr. Abdullah, Shehri, anyone. I'm happy and welcome to anyone anytime for any question or any assistance in anything. Thank you all, and Assalamu alaikum wa rahmatullahi wa barakatuh.
شكرا دكتور.
So by this we'll end up our activity for today, and see you inshallah next week.